Hello everyone, I'm Richard Conway from Dublin, Ireland, reporting virtually for Room Now from ACR 2023. I'm here to talk to you today about Abstract 1582. This was presented at Monday's plenary session number 2. It was by Bryant England and colleagues. It was non-TNF inhibitor biologic or tsDMARDs versus TNF inhibitors in rheumatoid arthritis ILD. So the reason this study has come about is that there has been this previous suggestion that TNF inhibitors are associated with increased mortality in patients with RA-ILD. There are a number of studies hinting at this. The main one was a BSR registry study, which compared TNF inhibitors to rituximab, showing worse outcomes with TNF inhibitors. Really, to many of us, this never really made mechanistic sense. TNF inhibitors are a fantastic drug for almost every other aspect of rheumatoid disease, among other conditions. They have not been associated with lung disease in a de novo fashion commonly at all. And why would they worsen this aspect of rheumatoid disease when potentially helping all other ones? So this is my favorite abstract probably from this meeting. It is such a smart study, very important clinical findings, and presented in a really, really nice way today as well. So this is a target trial emulation. It was using a new user propensity score matched design. It was based in the VA, so there's some caveats with that. So as you'd expect, this was largely male, 92%, largely older patients with a mean age of 68 years. And they compared non-TNF biologic or tsDMARDs to TNF inhibitors in patients who had RA-ILD. They enrolled 474 patients in this study. The non-TNF inhibitor patients, 53% of them were rituximab and 28% were on abatacept. And this is important because these are the two agents we favor in RA-ILD. We think these are our best two agents, and 80% of the patients being compared to TNF inhibitors were on one of these two drugs. Findings: so there was an adjusted hazard ratio of 1.22 for respiratory-related hospitalization for favoring the TNF inhibitors. There was no difference in all-cause or respiratory mortality. So this hazard ratio 1.22, it's not statistically significantly different. I mean, people could argue that the 22% potential increase, that is clinically important. It's within the error range of the study. But even if that is true, it comes down to the TNF inhibitor side. So really, I think this study largely exonerates TNF inhibitors from their previously suggested role in worsening outcomes in RA-ILD. I'm not sure it quite says that they should be the first-line agent. I don't think it'll change my practice to start initiating TNF inhibitors preferentially in patients with RA-ILD. But I think what it will say is if somebody's on a TNF inhibitor and they happen to have RA-ILD coincidentally, I'm not going to be switching them off the TNF inhibitor to give them a different agent, because this data really says that there is no need to do that. Remember to follow me on Twitter at Richard P.A. Conway, and check out Room Now for all the coverage from ACR 2023.